Welcome to the ARC's presentation on 988, which is a brand new development in crisis care. This webinar is intended to provide general information about what 988 is, how it came to be, and what we can expect at the federal and state levels, and also how disability advocates are responding to this new development that touches upon mental health, substance use, disability, and criminal justice. I'm Carlene Ponder, Director of Disability Rights and Housing Policy for the ARC. Joining me today are my colleagues, Michael Atkins and Juan Guerrero, who are both on the federal policy team. Co-hosting is the Autism Society of America. My colleague, Kim Mushino, is joining us. Thank you, and we will go ahead and begin. So in a historic move, the U.S. Congress passed bipartisan legislation designating 988 as the nationwide mental health crisis response number. The National Suicide Hotline Designation Act of 2020 was signed into law in October. The federal legislation requires that phone service providers direct all 988 calls to the existing National Suicide Prevention Lifeline. It permits a fee change associated with mobile or IP-enabled devices. This fee can pay for effective routing of calls to an appropriate crisis center and personnel and stabilization services directly responding to 988. The benefit of using the phone tax is that it becomes a stable revenue source to cover the hotline itself, and state legislatures don't have to address it year after year once it's authorized initially, making 988 less susceptible to budget fights. The Substance Abuse and Mental Health Services Administration, the federal agency that oversees the hotline, must ensure the hotline is equipped to provide specialized resources to high-risk populations. The statute itself specifically requests a detailed strategy in providing nationwide suicide prevention and crisis services for LGBTQ+ youth, minorities, rural individuals, or other high-risk populations. That other category is prime for persons with disabilities, including people with intellectual or developmental disability. The prevalence of a mental health condition amongst persons with intellectual and developmental disabilities is estimated to be 30 to 40% of that population. 30 to 40% of people with IDD also have a mental health condition. So the ARC and disability groups can advocate for specific training around disability. We can ask for peer supports to be part of any continuum of care that supports 988. And we can also ask for other resources, disability-specific resources, as states begin to implement 988 and corresponding crisis services. So according to SAMHSA, there are some best practices that they've released in a toolkit. Those best practices include having 24/7 clinically staffed call centers that can serve as the hub of an integrated mental health system, mobile crisis response teams that can respond to people who need on-the-ground support rather than law enforcement, and crisis receiving and stabilization facilities that provide short-term services rather than relying upon ER or hospital environments. SAMHSA sees 988 as a first step towards a transformed crisis care system. In much the same way as emergency medical services have expanded in the US, the agency believes that we can work to make sure that the rollout of 988 includes many of the practices and supports that are going to be needed to make anticipated call increases successful. To date, they've given $282 million to states to strengthen and expand the existing suicide prevention hotline, which includes text and chat capability. And also to build up staffing for local crisis call centers. Call centers are currently available in a lot of states. Many of them are operated by the same company that operates Lifeline, which will continue to operate 988. But with 988 being rolled out at the national level, it's going to be really important that staffing is adequate to handle the number of anticipated calls. I think currently in the crisis center that serves my local community, staffing capability is currently only at 90% of the calls that we get now. So that wouldn't be sufficient if 988 becomes a number that's well known and is utilized at a higher rate. So there's also new CMS guidance from the Center for Medicaid Medicare Services that was released in December 2021. The CMS guidance states that providing mobile crisis interventions is something that states can receive an enhanced federal medical assistance percentage or FMAP payment for. So typically, mobile crisis services would receive an FMAP, which is a federal match, would receive an FMAP of say 45 to 55%. So under the new CMS guidance, states who are either beginning mobile crisis services or enhancing their mobile crisis services can receive an 85% match. And they can receive that for the first 12 quarters. States can use their Section 1915C waiver to add or modify mobile crisis interventions. And states can claim, they can also claim an administrative cost for IT upgrades. IT upgrades could be made for things such as making sure that the hotline and associated services are capable of responding to people who, for example, have hearing impairments. So they could, so those administrative costs would be covered in the enhanced administrative claim. To be a qualifying mobile crisis team, one has to have a licensed behavioral healthcare professional. You should include other professionals such as trained peer support specialists, and all team members must be trained in trauma-informed care and de-escalation. So language considerations, including deafness, should be considered, and teams are to respond to crises in a timely manner. I know that in one community currently, we're pre 988 and pre all of the federal enhancements, that it can take a mobile crisis team up to 3 hours to respond to an incident. And I've heard police officers say that they often won't use that service because of that time delay. As you can imagine, if you're on the scene and you're calling a mobile crisis team to come out and it's going to take them 3 hours to get to you, is not really efficient. So the CMS guidance says, that the mobile crisis unit should respond in a timely manner. I don't think that that's defined. I have seen one best practice, I think, coming out of the state of Arizona, might have been Tucson, where their mobile crisis teams respond in 30 minutes when a call comes in from a police officer, and they make it a priority. So that certainly sounds like a much better option than a 3-hour wait. SAMHSA also considers a successful mobile crisis system one that avoids unnecessary law enforcement involvement and hospitalization. The CMS guidance encourages partnerships between mobile crisis services and schools, with a particular emphasis on reducing arrests for youth in crisis. So it'll be interesting to see how those school partnerships develop, should communities take advantage of them, and to see how these teams are able to interrupt youth being referred to law enforcement. And again, that's assuming that communities have teams in place that can support these types of needs. So now we're going to go back a few slides, actually. We're going to go back on the slide presentation to talk about something called disability justice. So you want to go back a few more. There we go. All right. So the term disability justice recognizes that the complexities of multiply marginalized disabled people aims to be holistic in recognizing these complexities. So the way that I think about it when we talk about disability justice is the intersection of disability, race, and in particular in this particular new development 988, I think about the intersection of law enforcement or criminal justice with disability. Currently, the lack of alternatives to 911 for people in crisis has left mental and behavioral emotional crisis response services to armed police officers. This has had a negative effect, including violent confrontations with law enforcement, the use of jails to stabilize people in crisis, and a lack of actual treatment for people in need of therapeutic support. Moreover, 50% of people killed by law enforcement have a disability. More than half of these are half of Black people with a disability have been arrested by the time that they turn 28. So those statistics are pretty daunting. And, you know, for advocates working in the space of disability justice, you know, we just believe that the outcomes of community crisis intervention should not include incarceration or involuntary commitment to a mental health or other locked facility. So, you know, we don't want to trade law enforcement and you know, that's one form of carceral involvement for another, which is going to result in people being you know, given treatments that perhaps they don't need, or being detained in a different facility rather than jail. So we, you know, those are two things to keep in mind. But I think my colleague Juan has some questions about this topic now.
Yeah, I know you mentioned it with 988 and the importance of disability justice, but